Well, hello everyone, and welcome to Dementia Unplugged. I'm Jeannine Forrest, and I will be the host of today's webinar. And I want to give a special thank you to Dementia Society of America. So again, welcome to everyone who's on the call. Right now, I just want to take a poll to see if you're experiencing any difficulty hearing me or seeing my screen. We're still in the beginning phases of learning all of this technical format. And so I'm going to unmute the participants. And I just want to see if any of you are having any difficulty.
Hello, Jeannie, can you hear me? Jeannie, can you hear me?
No, I'm not hearing any at this point in time. So let's go on with the program. Right now, I'm going to play a message by our president of the Dementia Society of America. It's a bit of a disclaimer that explains what this webinar is not intended to do. I'm going to read the disclaimer. All content, including any potential medical information, is provided as an informational resource only. It is not to be used or relied upon for any diagnostic or treatment process. It should not be used as a substitute for professional diagnosis, care, and treatment. Please consult your healthcare provider before making any healthcare decisions or for guidance about a specific medical condition. The opinions expressed in the content shared by Dr. Forrest are not necessarily the opinions and content of the Dementia Society of America. Thank you. So at this point in time, I am going to start recording. As we begin. So the topic is strategies to prevent or minimize agitation and distress. Before we get into the meat and potatoes of the topic, I understand that not all of you will be listening to the entire series. So what I want to do is just go over a brief slide that talks about sort of the difference of what dementia is and what's, for example, Alzheimer's disease or other dementias. So let me just hope to clarify that. I have a picture on the screen of an umbrella, and think about dementia as an umbrella term. Just like the word candy, there are many different types of candies, gumdrops, suckers, chocolate. In the dementia umbrella, there are many subtypes of dementias. So there are over 50 different types of dementias. For example, the most common or prevalent are Alzheimer's related dementia, vascular dementia, mixed dementia, Lewy body, frontal temporal, and the list goes on. Dementia in itself is not a disease. It's the expression of one or more diseases or conditions. It's progressive and tends to manifest itself according to each unique individual. Dementia is usually more than just memory. It involves a variety of cognitive functions such as mood, behavior, and also motor skills. There are some conditions that may mimic a dementia, such as depression, or a urinary tract infection is particularly problematic in older adults, and it changes one's cognitive ability. So I hope that gives you a little bit of a background before we get into this topic. All right, I'm showing a warning sign. And the warning sign ahead to me meant that I wish when I was a family caregiver for my mom, and as a matter of fact, I'm still helping my sister as a family caregiver, I wish I would have had better knowledge or understanding of why my mom was acting, to me, rather strangely, would get upset and irritable and often quite angry to situations that I didn't quite understand. So for many of my private clients and families that I visit and organizations, this topic of agitation and distress is a very, very common concern. And I'm hoping to give you some guidelines throughout our time together. So what I want to start out by saying is that distress, agitation in the forms of being irritable, maybe striking out, crying, moaning, that is not an expected part of one having dementia. It's common, but the underlying message is that it means there's an unmet need. I like to say that all behavior has meaning, whether it be what we would call challenging behavior. Say someone gets upset and is crying and we're not quite sure why. Or if someone's giving a loved one a shoulder massage, that interaction has meaning as well. Everything that we do is shown and communicated as a behavior, both non-verbally in the form of verbal, or in the form of facial expressions, body language, tone of voice. And when someone with dementia, a variety of dementias, any one of them, has an unmet need, and especially when there comes a time if they can no longer particularly articulate their needs, there's a lot of frustration that's built up. People get angry. And so you will see the distress and the agitation come out, often when you least expect it. It may be hours later. And ultimately, people behave in a way that we paraphrase this or coin it as challenging behaviors. And I'd prefer if people could say challenging behaviors versus just behaviors itself, because as I said, we all act and behave all the time. But we have to figure out, what are those challenging behaviors? Who are they challenging to? Quite often it's the caregivers and the professional care staff. So what I'm showing here is a diagram with the word challenging behaviors in the middle, and the 4 buckets of what I would like you to remember as the 4 major triggers or categories of why people with dementia get upset. The 4 are a caregiver's approach, a physical problem, such as pain. The 3rd could be an environmental problem, such as overcrowding, too hot. And the last one is an emotional distress. Perhaps the visit with a loved one didn't go as well. Or all of a sudden someone seems to recognize or remember that a loved one is deceased. And a small segment of why people become distressed and agitated is because they already have an underlying mental health problem, such as schizophrenia, bipolar disease, and that has typically been an established health and medical problem, and then a person develops their dementia on top of that. So let's start with Caregiver Approach, as I feel is almost the number one reason why people get obsessed, distressed and agitated. So imagine if you weren't able to be understood. You didn't have the words to articulate how you felt. And someone maybe well-intentioned is trying to get a better grasp of what you're trying to communicate. They may be talking to you more loudly. They may not understand, some of the changes in your ability to think, and they're getting frustrated, and you're getting frustrated on top of that, and there's just an escalation. Caregivers can often get frustrated over time, just fatigued, and that fatigue shows. And so that's often communicated to the person with dementia. So a couple of helpful hints for caregivers is really to look at your approach. The 4 S's seems to be a helpful way to think about it. Smile. Keep your message short, simple, and slow. That allows the changing brain to absorb your message a little better, and it allows the person to look at your facial expressions, knowing that you're a kind person. Use repetition. It doesn't help to speak any louder because it may feel or seem that the person doesn't understand, but using short, simple sentences to repeat. Break down a particular activity. So here's a gentleman about to brush his teeth. It may be helpful to cue and say, okay, first put the toothpaste on the toothbrush. Now bring it up to your mouth. Now begin to move the toothbrush in a circular motion. So breaking down the steps is always helpful, as opposed to just saying, okay, time to brush your teeth. Narrow down choices. Don't make it overwhelming. For example, it doesn't help to say, well, what would you like to do this afternoon? A person with dementia who's having problems with their frontal lobe and executive functioning and planning, that question may seem too vague and overwhelming. So, would you like to watch a movie, or would you like a hand massage? The next thought here is think about yourself and the way you interact. Are you a friend to this person, or are you the foe? And in order to be the friend, you're using dementia-friendly language. If you're caring for an adult, one would not want to say, well, let's put a bib on you so you don't dribble, right? Look at how you lift someone up as opposed to bringing down someone's dignity. Check your body language. Are you open and friendly? Compliment frequently. A person with dementia, can often feel like they're just not getting anything right and feeling very discouraged. So just anytime someone attempts to help, compliment. Thanks so much for helping to set the table. Thanks so much for helping to wash your face. And another approach a friend would do would be apologize. Even if you have a sense that it really isn't your fault of what's happening, or you don't quite understand, or someone's upset, a good way to approach this would be to say, I am so sorry that you're not, you're upset. I'm so sorry that you seem so anxious. In another slide, I recommend that you do not try to argue or rationalize. The person with various types of dementias have difficulty with insight, and that part of the brain is just becoming more and more problematic. And the more you try to convince someone that For example, they shouldn't be driving, they're not safe, and they feel they're just fine, thank you. You could end up with a back and forth, just ongoing sort of frustration match. And so I would recommend that you try to really try to distract the conversation, try something else, come back later. The next bucket of triggers of what causes distress is physical distress. And so this may be someone has a full bladder, someone is hungry and can't communicate that. The most common is an underlying pain or a discomfort that's not recognized. Some of those risk factors for pain are history of arthritis, back pain, sciatica, diabetic neuropathy. People come into their dementia often with these conditions. Having dementia does not cause pain, but people do come in with maybe cavities, poor oral health. And if the person can't describe or pinpoint the problem, often that does not get recognized. Another one is pressure sores. If people have bed sores, that could be a problem. Those are uncomfortable. Falls. Here's one. If someone falls in the morning and later on they're bruised, they may not remember the event took place in the morning, and still they're uncomfortable. And so we have to look at what's the antecedent, what happened within the last 24 hours that may be uncomfortable, or is there a chronic condition that underlies the person's comfort? Another one is contractures. The word contracture means sort of severe stiffness in one's joints and muscles. And this in and of itself can be quite uncomfortable for someone's limbs, their arms, their legs, their wrists. So often in this case, we have to really look at what non-drug and maybe analgesic pain medicine may be useful in addressing someone's pain. I like to say that people who are comfortable and safe do not, and I'll repeat, do not cry, moan, hit, or scream. That's for all of us, with or without dementia, but particularly with people with dementia. If they are comfortable and safe, will not cry, moan, hit, or scream. And if this is happening, we need to be the detective, because there is some unmet need that needs to be addressed. It's not the dementia getting worse. Another vulnerable factor for someone to be in distress is that they sit in the same chair for too long of a period, longer than 2 hours. Imagine if you sat in the same chair, maybe being toileted once or twice in an 8-hour period, and then add on top of that a history of sciatica or back pain, that would become unbearable. But unfortunately, this is what I often see in some care facilities, that a person will be up early in the morning, brought to their breakfast table in the wheelchair, stay in the same wheelchair through activities and lunch, and by afternoon, they are just miserable, and people just don't know what's happening. And in some cases, the person may be even hooked up to some type of chair alarm, with people are saying, sit down, when the person is really just trying to get more comfortable by standing up. So something to really consider. How long is your loved one or resident or patient sitting in the same chair? One way to relieve this discomfort is through exercise. There's a lot of research happening in the field of dementia and how exercise can not only boost one's mood, but it certainly plays a role in keeping muscles relaxed, joints flexible, and preventing all sorts of distress. And I'll talk in a minute about how exercise should be part of one's daily schedule. In the slides, we have a lady doing light weightlifting, a gentleman doing Tai Chi, and just walking. So here's that slide of routine. In the routine, this is just an example. I have someone waking up with breakfast and doing some meaningful work, painting, a little exercise. I always embed some type of rest period in the morning and before dinner. It plays a significant role in allowing the brain to rest, to not be overstimulated, because what we're finding, if someone just goes from activity to activity to activity throughout the day, often by 3, 4 o'clock, this is when a condition, sometimes known as sundowning, comes into effect. I'll have a slide later, but it really has nothing to do with the sun. It just means that a person is over fatigued. So routine schedule is very important in minimizing distress and agitation. The other category or trigger is the environment. Clutter can play a role in making someone a little agitated or distressed. I just think of myself before I'm ready to do a project or get ready to sit and write or something or that I need concentration. I have to declutter my office. Same happens with people with dementia. It's just too overstimulating. So look at the environment. Keep clutter away, especially on the floor, in pathways to prevent falls. Look at the environment in terms of sound. Is it too noisy? Is there a TV blaring in the background? Are there people, too much noise? So that's a real consideration. May need to turn off that television, quiet that radio, close the door. It takes effort to focus on conversation when one has dementia. And so it's so important to make sure the background is quiet. The last bucket or trigger for distress is really an emotional one. Here's where someone may want to feel like they're not at home. I want to go home. I want to go home. Well, in fact, we know that the person doesn't want to go to their physical home. What they're communicating to us is, I don't feel like I'm at home. I don't feel I'm with people who know or love me. And so we want to address that anxiety and let people know, I'm with you. You're safe with me. The other aspect is if someone has some form of mental illness underlying, that the person is receiving the right amount of medication that's been controlling some of their symptoms in the past. I show a slide on hallucinations and delusions. Hallucinations can be by sound or by sight, where people hear or see things that don't exist, that sometimes can occur just from the dementia itself, and delusions, feeling as if you're someone else. But oftentimes it really occurs because they have an underlying mental illness. I separate this because there are what I would say good hallucinations and not so good hallucinations and delusions. If someone is seeing beautiful butterflies floating and they're not distressed, then we don't have to be as, I would say, as concerned about, oh my gosh, do we need some medication? Is there more we can do? Just kind of go with it and enjoy that experience. But if in fact the person feels that there are police are out to get them, or someone's hiding in the walls, and the paranoia develops, then more interventions need to be integrated into their care. Same thing with the delusion. If I think I'm the Queen of England, let me have my lovely delusion. I'm not hurting anyone or yourself or anyone around me. So it's that kind of need to distinguish the type of hallucination and delusion depending upon the next steps we need to take. So getting back to distress. Here we have a gentleman with his hand over his face. His body language is telling me he's upset about something. So think about those 4 buckets. What could it be? And one major intervention or strategy that I'll always tie in is to respond with compassion, regardless of if it's a physical, environmental, emotional, or your approach. The idea is to respond with compassion. Listen to the underlying tone of their voice, especially if words aren't as articulate or there's just a few words being used. Listen to the underlying tone. Are they scared? Are they angry? Provide reassurance. The last thing someone with dementia wants to feel as if they're just being they're invisible, and their distress is invisible. So I'm sorry that you're sad. I'm with you. You're safe with me. That's an important way of addressing this and helping to minimize. Other strategies include finding meaning in the day. So in terms of not being bored, one can't just sit and watch television all day. Think about their favorite hobbies and preferences. Is it a pet? Is it planting? Is it art and music? There's more and more research about the significance of melody and music and tempo in calming people with dementia. One other sort of sidebar here is that there's this other concept called acute confusion and delirium that's different than dementia. Acute confusion, the other technical word is delirium, means that there is a sudden onset or change in one's ability to concentrate and focus, and you may have an escalation of hallucinations. And it often seems to come out of the blue. So someone with dementia could have their baseline behavior, but all of a sudden they can't seem to keep their eyes focused on you, conversation, they're picking at the sheets, they're upset, they're afraid, they're anxious, they're angry. If that happens suddenly, that's not the dementia getting worse. That is a medical problem that needs to be addressed immediately. And the common underlying factors for that is, number 1, usually some type of infection, which would be a bladder infection, a UTI, or even a respiratory infection. The second is we could have a lack of oxygen. The third is that there's maybe too many medications that are interacting. And the fourth is poorly controlled pain. This was established in a few research studies really in about 1997 that has shown that poorly managed pain can end up as acute confusion in people with dementia. I have the slide on sundowning, and I spoke about it a few moments ago, but I do want to say again that sundowning has nothing to do with the sun. Our research and my clinical experience show that it could almost be 95% eliminated if individuals are allowed to have some rest periods. And those rest periods can look like just having quiet time, maybe quiet music in the background. Some people pray, some people take a nap. It could last for 30 minutes, 45 minutes in the mid-morning and then before dinner. making sure that they're comfortable, no pain problem. So those are the types of interventions that really help to eliminate this problem called sundowning. I want to sort of close with my talk and talk about discussing non-drug strategies with your care provider first, before just jumping onto the use of sedatives or antipsychotics. We find that often it's sort of a knee-jerk reaction. Someone gets distressed, upset, and looking for a magic pill or drug. Well, unfortunately, many of these medications have pretty severe side effects. And the example I give is if someone's sitting in the same chair for 8 hours, and now they're distressed at 3 in the afternoon. Well, I've seen individuals receive Seroquel, an antipsychotic, because they're upset and want to get up out of the chair. When in fact, that's not going to help at all. That will only make someone sedated for about 4 to 6 hours. That will not get at the core reason why someone's upset in the first place. What they need to do is get out of that chair, stretch out, maybe have a back massage. They may need some ibuprofen to address the joint pain, and no Seroquel or Ativan or anything like that is going to help if you don't address the core underlying condition. So always discuss non-drug strategies and see if they can help first. All of these strategies and ideas and suggestions I bring to you because we're really learning to care. We've got a while before we find a cure. And so in the meantime, we're really trying to address quality of life for our loved one with dementia or our resident or patient. And so we do have strategies that can help while we're finding the cure. So before we go on to question and answer, I want to give a big thank you to the Dementia Society of America for hosting this program. It's an all-volunteer driven organization. There's information on the slide or the website about how to give donations if you wish. But as you know, these webinars are free of charge. And at this point, I am going to stop our recording. All right. And I'm going to be opening it to questions and answers.